Oppositional defiant disorder versus conduct disorder. A very amazing presentation slash video from group 16. Oppositional defiant disorder. This is Mark from the movie The Good Son, and he's a pretty cool character. So, oppositional defiant disorder is characterized by a frequent and persistent pattern of angry or irritable mood, argumentative or defiant behavior, and vindictiveness over a period of at least 6 months. Criteria A is fulfilled by at least 4 of the 8 symptoms exhibited during interactions with at least one individual who is not a sibling. These symptoms should be considered excessive for what's normative of an individual's age, gender, and culture. To diagnose ODD, one would also need 3 other symptoms of the disorder on most days for 6 months. To meet criteria B, the disturbances are associated with distress in the patients and can also be met if the disturbances in behavior have negative impacts on important areas of function. Criteria C excludes behavior that's exclusively due to a psychotic episode, substance use, depressive, or bipolar disorder. Now, it's important to recognize that ODD can be confined to only one setting, but in more severe cases, you'll also see it manifest in multiple settings. When diagnosing an individual with ODD, it's important to rule out other conditions, such as conduct disorder, which we'll get into in a bit, ADHD or attention deficit hyperactivity disorder, a mood disorder, disruptive mood dysregulation disorder or DMDD, intermittent explosive disorder, intellectual disability, a language disorder, or a social anxiety disorder. There are various similarities and differences between these conditions, which you can read on this slide. ODD is a relatively new diagnosis for criteria that don't meet the threshold for conduct disorder, so not much is known specifically about the etiology and or pathophysiology. Psychosocial factors can include instability at home, specifically around inconsistent parenting. Neurobiological factors are associated with ODD. Neurobiological factors include a lower heart rate and skin conductance reactivity, reduced basal cortisol reactivity, and abnormalities in the prefrontal cortex and amygdala. These biological findings, however, are also consistent with the conduct disorder. So, now, there are some risk factors for ODD, and these risk factors include problems regulating emotion. For example, a low tolerance for frustration. The home environment can also be a risk factor, and children and adolescents receiving harsh and neglectful parenting and overall inconsistencies in parenting. For example, if there are many changes in who the caregiver is, are at an increased risk for developing ODD. The prevalence of ODD ranges from 1 to 11%, with an average prevalence estimate of around 3%. The ODD rates may vary depending on age and gender, but the disorder appears to be somewhat more prevalent in males than in females prior to adolescence. However, the male predominance is not consistently found in adolescents or adults. Now, the first symptoms of ODD usually appear during the preschool years and rarely later than early adolescence. And ODD often precedes the development of a conduct disorder. However, many children and adolescents with ODD don't even develop the disorder at all. ODD also conveys risk for the development of anxiety disorders and major depressive disorders, even in the absence of a conduct disorder. People with ODD are also at an increased risk for a number of other problems and adjustments as adults. The initial treatment of ODD should include psychosocial interventions aimed at changing the maladaptive patterns of interaction between the child and his or her family and environment. A multimodal approach to ODD may include psychotherapy for the child and for the whole family, school-based programs, problem-solving skills training, and parent management training. Medications are never used alone to treat ODD, and they should only be used if psychosocial treatment alone is not effective. There are currently no medications approved by the FDA for the treatment of ODD. Now, the next disorder we're going to talk about is conduct disorder. This is Henry from the movie The Good Son as well. Now, you could think of him as your archetype for a conduct disorder, where, Henry was killing animals, poisoning food, and killing people. He absolutely had no sense of basic rights of others, and he also had no limits. Many children and teenagers may have behavior related problems without having a conduct disorder. A child or teenager that's diagnosed with a conduct disorder must display a repetitive and persistent pattern of behavior in which the basic rights of others or major age appropriate societal norms are violated. Now, those are very big buzzwords for a conduct disorder. For the past 12 months, the child must also display at least three of the criteria that's listed on the following slide. And for the past 6 months, the child must also display at least one of the criteria listed on the following slide. Here's a list of the 15 possible criteria for a conduct disorder. You'll notice that there are four main categories of the criteria, and a good mnemonic that you could use to remember the four categories are TRAP, T-R-A-P, and the T stands for theft, then rule breaking, A for aggression, and P for property destruction. You may want to pause the video so you could review the criteria on your own. When diagnosing an individual with a conduct disorder, it's important to rule out other conditions such as ODD, ADHD, mood disorder, intermittent explosive disorder, and adjustment disorders. As before, there are various similarities and differences between these conditions. Also to note, conduct disorder is similar to ODD in that they both involve conflict with figures of authority. However, ODD behavior is typically less severe than conduct disorder and does not include aggression towards people or animals, deliberate destruction of property, or a pattern of theft or deceit. Now, the 1-year prevalence of a conduct disorder is estimated to be between 2 and 10%. The disorder tends to be more common in males, with up to 8% of boys under the age of 18 meeting the criteria, compared to only 3% of girls. Now, although conduct disorder can occur in children as young as their preschool years, the first significant symptoms usually appear between middle childhood and middle adolescence. The onset is rare after the age of 16. Oppositional defiant disorder is a common precursor to conduct disorder, particularly for the childhood onset subtype. In addition, early onset of symptoms typically suggests a worse prognosis and the continuation of behavioral problems into adulthood. In most cases, the disorder will remit by adulthood. However, an estimated 40% of boys and 25% of girls with conduct disorder will go on to develop adult antisocial personality disorder. The etiology of conduct disorder is multifactorial. However, psychosocial factors have been shown to have a major role in the development of conduct disorder. Some of these factors include childhood abuse, childhood trauma, parental separation, and poor forms of parenting such as rejection, abandonment, and excessively harsh discipline. There are no highly specific neurobiological factors that may be attributed to the pathophysiology of conduct disorder. There are some findings that show that conduct disorders are associated with an increase in psychomotor seizures and neurological soft signs, such as rigidity and gait imbalance. There's also a genetic component to conduct disorder, as evidenced by studies that show that adopted offspring of female felons have higher rates of antisocial behavior. As mentioned previously, several psychosocial factors seem to be associated with an increased risk for conduct disorder. Children from families that have increased prevalence rates of antisocial personality disorder, a mood disorder, substance abuse, and learning disorders seem to be at an increased risk for development of a conduct disorder. Also, parental separation, substance abuse, and poor forms of parenting all may contribute to the development of a conduct disorder. Finally, higher instances of diagnosed conduct disorder are observed in children that are adopted. Treatment for conduct disorder is highly variable and depends on many factors, including the individual's age, symptoms, comorbidities, and family support. Typical interventions are individual and family therapy. Medication is typically not used in the treatment of conduct disorder unless it's used to treat other comorbid disorders. Still, some drugs such as lithium carbonate, psychostimulants, and second-generation antipsychotics are occasionally prescribed in extreme cases to reduce aggression. Now here's our USMLE review question. You may wish to click pause now. The correct answer is D. Please see the slide that contains criteria A. Here's another question. Please pause. The correct answer is D. This is because the child is defiant but causes no harm to other people.